Hello, my name is Megan Best. This is a recording of a presentation which I gave in Newcastle on the 3rd of August 2024. It was entitled Living with Voluntary Assisted Dying. Legalisation of Voluntary Assisted Dying, or VAD, in Australia has radically changed the healthcare environment. It has overturned therapeutic norms to the extent that those who were providing what has until now been known as best practice at the end of life are being criticised for being uncompassionate or negligent if they refuse to kill their patients. VAD legislation creates ambiguous care environments which alter the focus of institutions and erode trust in relationships between healthcare workers and their patients. Please note that at the time I gave this presentation, I had a severe throat infection, so my voice sounds quite squeaky. This is not a problem with your computer. Thank you.
This was in a Sydney newspaper last week. So the state government has decided that all new legislation has to be reviewed to see what the impact is on suicide rates, because it's such a problem, and they talk about needing to review legislation in housing and health and education, but there's no mention of the elephant in the room. The fact that we've legalised physician-assisted dying, and there's very good evidence that unassisted suicide rates go up when you legalise assisted dying. So how can we as Christians navigate our way through this new healthcare environment when so many people have blinkers on about what's really happening? So as Catherine's already mentioned, I'll be addressing these points as I go through. But before I start, I want to acknowledge that to make a decision that death is preferable to life is something that happens when you're experiencing significant distress. And I don't want to minimise the suffering of patients at the end of life when I criticise VAD. However, I firmly believe that it's wrong to relieve suffering by killing the sufferer. For over 2,000 years, euthanasia, where a doctor kills a patient through administration of a poison, has been a prohibited medical practice. The Hippocratic Oath is an oath of ethics that was historically taken by physicians. It was originally written in Greece between the 5th and 3rd centuries BC, but by the 4th century AD, it had become standard for the medical profession. And in that oath, doctors would say, "Neither will I administer a poison to anyone when asked to do so, nor will I suggest such a course." Some of you might have heard me tell a true story where someone asked me, when they do euthanasia, do they sterilise the needle? And I thought, well, that just shows how antithetical euthanasia is to the practice of modern healthcare, because normally we wouldn't dream of not sterilising the needle. But if the patient will soon be dead, it really doesn't matter. So euthanasia and physician-assisted dying are not legitimate healthcare practices according to the World Medical Association, regardless of what our government legislates. So how did we get to where we are now, where euthanasia and physician-assisted suicide are listed by our government as standard medical interventions for patients at the end of life? And why are healthcare workers expected to do it? It's not inevitable. In Switzerland, healthcare practitioners do not administer euthanasia. Now, in the modern development of euthanasia laws, after World War II, discussion of euthanasia understandably dropped away after the appalling atrocities of Nazi Germany. But modern discussion of mercy killing began in the Netherlands in 1969 with the publication of a book by a Dutch psychiatrist entitled Medical Power and Medical Ethics. And the idea proposed in that book was that doctors cause so much suffering through over-treatment of patients that it's their responsibility to undo the pain and suffering they caused by killing the patient. And around the same time in the USA and UK, there were some very high-profile court cases where people were fighting against the medicalisation of death and fighting for the right of comatose patients to be allowed to die. So it was really over-treatment of patients that led to public criticism of end-of-life care and calls for euthanasia to allow people to escape from the living death of technically assisted existence. Now, while all these cases were complex in their own way, they represent a failure of modern medicine to not only ask, how can we prolong life, but should we prolong life? And as concern for death with dignity followed a pattern of neglect of the needs of the dying, it also illustrates how the phrase dying with dignity came to be associated with the push for legalised euthanasia. Next slide, please. Euphemisms abound in this conversation, but it's important that we're aware of the terms we use because they do impact our moral evaluation of the practices in view. Australian legislation uses the terminology of practitioner-administered VAD or self-administered VAD to distinguish euthanasia and physician-assisted suicide. In Canada and increasingly in the US, they have medical aid in dying, which they call MAID, and in the UK they still tend to use the term dying with dignity. But the actual practices they're describing are euthanasia and physician-assisted suicide. The terminology of VAD aims to distance the practices involved from the ideas of suicide and killing. However, suicide and killing are the most accurate descriptions of what's happening. According to the actual legislation, a person who dies by VAD in Australia does not die by suicide. Now, the reason that was written into the law originally was so that it wouldn't interfere with claims on life insurance policies, and also it was to stop police from jumping in and interfering with the procedure. But pro-VAD groups grasped hold of it and thought this was a great way to make it more palatable to the general public. And so you'll hear a lot of people being quite strident and saying it's not suicide. But from a moral perspective, there's no basis for saying VAD isn't suicide. And it was taken to the Supreme Court. I'll go to this a bit later, but they agreed and said it really is suicide. So VAD is a legal term only. We need to keep using the terms that most accurately describe what is happening. I heard a talk from Theo Boer, who was one of the founders of euthanasia in the Netherlands, and it was actually quite refreshing to hear that the Dutch define euthanasia as doctors killing patients by administering poison. I thought, well, you know, what you get is what you see, and in a way that's quite nice. So legislation of euthanasia and physician-assisted suicide was the result of social change in Australia. With the rise of individual autonomy, there was a rise in the consumer voice and a focus on informed consent in healthcare. And that actually brought a lot of good things. It reduced the amount of paternalism in healthcare, which is a positive step. But the elevation of patient autonomy and patient-centred care has also led to the situation where patient autonomy is now seen as the most important ethical value in healthcare decision-making in Australia. And promoting patient choice is seen as the greatest ethical good. The medicalisation of death as well has meant that death is separated from life. Most people in Western countries die in hospital, and so the fear of death has continued to rise in the community. With the fall of religious affiliation, which might be one way with which people could cope with the existential fears around death, we have this situation where medicine can prolong people's lives, but that might mean they live longer with disability and degeneration, and it's possible that the process of dying is prolonged. So all these factors have worked together. So we have a situation where 85% of the population have said they're in favour of legal VAD, which is another story I won't get into. But it might have been inevitable that with the push for right to die legislation, that the laws would be passed for VAD. No one talks about it much, but another reason for passing the laws is it's going to save the government a lot of money. This is a paper that was published in Canada soon after the legalisation of MAID in that country. And it estimated that the Canadian healthcare system would save up to $136.8 million per year in 2017 because of VAD, despite the costs of implementation. And their profits would have increased quite a bit because the rate of MAID has increased 15 times since then. In Australia, legislation concerning end-of-life issues is dealt with on a state basis. The first voluntary euthanasia bill was actually introduced to an ACT parliament in 1993. Obviously, it didn't pass. But there was widespread community support for the idea, particularly in Victoria, and the Dying with Dignity Victoria was established in 1974. In 1985, the Victorian Parliament was the first Parliament to raise the issue when it appointed a parliamentary committee to look at the right to die. In 1988, Victoria passed the Medical Treatment Act, which enshrined a patient's right to refuse medical treatment. In 1991, Helga Cusey and Peter Singer, philosophers in Victoria, published a paper saying that 75% of nurses were in favour of a change of the law to allow euthanasia, and 65% would be agreeable to administer it if it were legal. I remember it was front page news when it came out. The first legal euthanasia in the world came with the passing of the Rights of the Terminally Ill Act in the Northern Territory in 1995, through which Dr. Philip Nitschke, a GP in the Northern Territory, helped 4 people to die before the law was overturned by the Howard government's Euthanasia Laws Act in 1997. It took another 2 decades and nearly 60 failed bills around the country before Victoria passed the Voluntary Assisted Dying Act in 2017. The reason so many bills failed was because legislators couldn't see how you could safely construct a bill allowing euthanasia. Particularly the abuses in Netherlands and Belgium led to the rejection of legislations. But in the face of the overwhelming evidence from the Low Countries that the legislation was being abused, the pro-euthanasia activists said, well, we're not going to base our law on what's happening in the Netherlands and Belgium. We're going to base our legislation on Oregon, USA, where physician-assisted suicide was legal but not euthanasia. They said that physician-assisted suicide has been practiced safely for years in Oregon with no evidence of abuse. And that's correct. There's no government record of abuse because the Oregon government doesn't keep records for its physician-assisted suicide that captures any of the nuance of what's happening. The government themselves has admitted that they can't say exactly what's happening on the ground because it relies on doctors' self-reporting, and there's no enforcement provisions to check on what's actually done. But non-government research has found that the seemingly reasonable safeguards for the care and protection of terminally ill patients are being circumvented, and suggests that the data collection is in place to protect the government and the lawmakers rather than the terminally ill patients who access the law. In fact, evidence suggests there have been harmful unintended consequences for patients, including the death of patients who are not mentally competent or not terminally ill. But when concerns about the adverse consequences of permitting euthanasia are raised, advocates tend to dismiss them because they were unfounded and speculative and not reported, but the dangers remain nonetheless. We know there are problems in Australia, but as we're modelling ourselves on Oregon, the government reports are brief and uninformative. Interestingly, in the end, our legislation is not based on that of Oregon because we have euthanasia and physician-assisted suicide, and they just have physician-assisted suicide. Nonetheless, the parliamentarians were appeased, and in the face of overwhelming popular support, the laws were passed. Now, there are similarities across all states. All the laws are different, but there are a lot of similarities, although there are significant differences. When the Victorian law was passed, the Premier Dan Andrews described the laws as the most conservative euthanasia regime in the world with the most safeguards. However, since then, people have seen the safeguards put in place as barriers to access. So as the laws were sort of moved their way across the country, these safeguards have been gradually reduced. And I think the variation between states also shows how unsure legislators are about what's required to safeguard euthanasia. So in all states, you can see there, to be eligible to access VAD, a person must meet a range of criteria, including being a mentally competent adult who acts freely without coercion, an Australian resident or permanent resident. They must have a disease, illness or medical condition which will cause death within 6 months in most states, excepting for a neurological disorder, which is 12 months. In Queensland, it's 12 months for everyone, and the recent ACT legislation doesn't require a prognosis. The patient's condition should be advanced and causing intolerable suffering with no treatment that is acceptable to the person. So treatment can be available, but if they say, I'm not happy with it, they're still eligible. In all states except Tasmania, the condition must also be progressive. To access VAD, a person must undergo a request and assessment process that includes making at least 3 separate requests for VAD and eligibility assessments by at least 2 independent medical practitioners. You can see the variation between states on this table and how it became more liberal over time. With regard to prognosis, it was initially 6 months for most patients, but pushed to 12 months in Queensland. And as I said, in the ACT, they've passed laws where no prognosis is required. The law requires the person is diagnosed with advanced progressive disease that is expected to cause death, but in the legislation it actually says a patient may be approaching the end of life even if death is not expected to result within the next 12 months. So it's really quite elastic. Now, in Victoria, the first law, they didn't allow a healthcare practitioner to suggest VAD to a patient, but this was very quickly changed. It was seen as a big barrier. And to see the impact of this change, in the first year of operation, 124 people died under the Victorian legislation. Next state was Western Australia, with healthcare professionals suggesting VAD. 190 people died within the first year, despite a smaller population. just to give you, and now in New South Wales, 131 people died in the first 3 months. So it's not really surprising, because if a doctor makes a recommendation to a patient, it's generally seen as prescriptive. And I'm not surprised that it's increased rates. Euthanasia initially had to be oral unless there was a physical reason why a patient couldn't take the oral medication, in which case they could have an injection by a practitioner. But once again, this was seen as discriminatory. So this has moved to being a choice for the patient, and the patient can make a choice as to whether they have oral or practitioner-administered medication. We know from evidence overseas that when there's a choice, most patients choose euthanasia, and the rates go up quite dramatically. In New South Wales, the first report suggested around 70% of patients are going for the IV route. There was an interesting study done with Canada and California. California in the US only allows physician-assisted suicide. Canada allows a choice, and about 99.9% of patients choose the IV route. These are two jurisdictions with the same population. They legalised assisted dying at the same time. The Canadian rates of patients dying is 15 times that of California. It makes a huge difference. Also, abuse is much more likely when it's practitioner administered. The reasons patients prefer the IV route is probably because it's more reliable. We've got accounts of people still being alive 24 hours after taking the oral medication. It's hard, I think, to decide to kill yourself. And when a doctor or someone in a white coat does the injection, it provides a false legitimacy that it really is a medical procedure that makes it more acceptable for everyone in the room. Next slide, please. I really recommend, and I know people listening to this are coming from across the country, but I recommend that everyone downloads the legislation for their own jurisdiction to actually read through the law. All the links are in the handout. There are a lot of problems with the Australian laws. The fact that doctors can make a suggestion to patients that VAD might be a good thing to think about. I heard one patient say, well, they went to see their oncologist and he said, well, you know, the chemotherapy's not working. It might be time to see the VAD doctor. The legislation they presume that a patient's decision-making capacity is intact, despite us knowing that people with advanced disease have a very high risk of cognitive decline. Doctors they have to give advice to the patient about their prognosis according to their disease, the palliative care treatment options, and they have to assess mental capacity. But they don't actually have to have training in any of those areas before they give that advice to the patient. And we know that some patients are dying prematurely because they've been given a false prognosis or a wrong prognosis. No psychiatric assessment is required to determine mental competency. It's an option open to the doctor, but it's not required. And mental illness is not a disqualifying factor for accessing VAD. That's particularly concerning when you think the rates of depression, potentially treatable, have been measured as up to 45% in cancer patients. A palliative care study in Victoria that was just published said that about a third of the patients had clinical depression and over 40% had clinical anxiety. VAD doctors, we know, are making mistakes, but there's no pathway to correct the mistakes. Most of the checks occur after the death. And so the people who are reviewing the board, reviewing the applications, only one of them is a practicing doctor. The rest are lawyers, and there's a dentist. Pressure is on to allow telehealth for review of patients for eligibility assessments, which would reduce the opportunity to see whether something like coercion is a factor in somebody's decision. Happily, since the federal court ruled that VAD is a form of suicide, there are federal laws that block the use of telehealth for VAD, but there is a lot of pressure from all the states to allow it. Another problem is there's a lack of doctors willing to do the deed. This is an advertisement that the VAD navigators in Victoria put out. Look at the second paragraph. Training days are a fun and efficient way to get the training. If I went to one of the support groups for VAD workers in Australia, and the word I would use to describe their interaction is jolly. It was a jolly. I wonder how much of it is subconscious discomfort about what they're doing. But we know that, we don't know from the government reports, we know from research that most of the deaths that occurred in the first year in Victoria were done by just 4 doctors. But one of the changes in legislation with the reluctance of doctors to provide VAD is that now nurses are also, in some states, can assess eligibility and administer drugs. Canada has addressed this problem in a different way. In 2019, they passed a ruling that physicians can be forced to facilitate procedures which they find morally objectionable, including euthanasia and assisted suicide, by connecting patients with willing providers. This is known as effective referral. Definitely in many healthcare districts in Australia, there is pressure on physicians to comply with the VAD guidelines, and some people are finding that quite difficult. We'll talk about it more later, but perhaps the saddest problem of all is that legalisation of euthanasia has moved the focus away from providing excellent end-of-life care, with healthcare funding being moved away from palliative care to fund VAD programs. The premiers of both Victoria and Queensland publicly said they didn't have enough money to provide palliative care to everyone who needed it in their state, but they can afford to provide VAD. The New South Wales Labor government slashed $150 million from palliative care funding in the last state budget, while putting $97 million into the implementation of VAD. But really, by legislating VAD, it's completely taken governments off the hook with regards to the need to provide good end-of-life care. Now, apart from issues of patient safety, how are we as Christians to think about VAD? Well, the message of the gospel is a message of freedom from the fear of death. All human beings face death, and it's something that is fundamentally out of our control. Death reminds us that we are creatures, utterly dependent on our Creator. Yet for human beings, death is not merely humbling, but also threatening and fearful, because we face it not merely as finite creatures, but also as sinners. Paul tells us that the sting of death is sin. We face death, therefore, as those who have failed to live our lives as we were made to, and stand condemned and under the wrath of God. However, as Hebrews tells us, the Lord Jesus Christ, Son of God, shared our human condition so that by his death he might break the power of him who holds the power of death and free those who all their lives were held in slavery by the fear of death. Christ's conquest of death brings us the freedom to face death without fear, to submit to it and face it with confidence and hope as a final trial through which we must pass, and beyond it which lies glory. It allows us to accept and even welcome death when it comes, because of where it leads us, in hope of the day when death will be swallowed up in victory through resurrection. Christians thinking about suicide should begin from this understanding of life and death, the fear of death, and the gospel's promise of freedom and life in Christ. To the despair of suicide, the gospel speaks a word of hope. It says that in Christ there is forgiveness and power, a path to walk in faithfulness through darkness, a community to walk with, and the promise of a future of unimaginable joy and glory where God will wipe away every tear from our eyes. It urges perseverance, even in the face of great dismay and confusion. And it assures us that however terrible our sufferings, and they are indeed often very terrible, they are not worth comparing to the glory that awaits us. In suicide, there is also, however, an element of defiance, and this defiance is quite complex. There's something deeply understandable in the desire to refuse to let one's life be defined by mental anguish, physical deterioration, or pain. This defiance can reflect a strange affirmation of what's good in life. Yet there's also an element of pride in this defiance, for fundamentally it represents a refusal to accept our condition as creatures and God's right as creator to give and take life. And it represents a loss of faith in God's grace as Redeemer to sustain perseverance and hope in the face of suffering and despair through the promise of life in Christ Jesus. For this reason, suicide should be clearly named as a sin. The wrongfulness of suicide is marked out by the law in the 6th commandment, "You shall not murder." This is a quote from a respected commentary. The sixth commandment is perhaps best understood as stating that no human being may take a human life without divine approval. By including this prohibition against the taking of human life, Yahweh underscores the idea that no human has the authority to destroy the life of another. It recognises that the deliberate taking of human life is a special boundary that must be carefully safeguarded because human beings are created in God's image. Stories of suicide and assisted suicides in the Bible therefore all reflect a clear sense of shame and failure. A biblical example that supports the prohibition of euthanasia is the story of the death of King Saul in 2 Samuel chapter 1. I'm sure you've heard the story. David has just become king after the death of Saul. A few days later, an Amalekite man comes to David and claims he found Saul gravely injured on the battlefield and that Saul had begged the man to kill him rather than fall into the hand of his enemies. The man had done so at Paul's request, and David's response is to call for the execution of that man on grounds of having killed the Lord's anointed. This story, as well as the 6th commandment, teaches us that it is morally wrong to actively take the life of a terminally ill person, even if they ask to be put to death. It's a form of murder. To insist that suicide is wrong is, of course, much less than what is needed in terms of a pastoral response to somebody who requests VAD. But we need to remember this teaching because it is all too easy to be seduced by our community's arguments of the goodness of mercy killing. So what is the role of the Christian doctor when a patient expresses a desire for hastened death? I'm now going to focus on the New South Wales legislation, but the principles apply to all states. The actual act, there's a link to it in the handout, but each health department has also developed guidelines for how you should respond to VAD requests. The links are also in the handout. Now, first, do you have to raise VAD as a legal option to your patients? Well, don't do it in Victoria. It's against the law in Victoria. But according to the New South Wales legislation, there is no duty for a medical practitioner to mention it to a patient if the patient doesn't say anything. This is against some of the... I know that there are some local health districts that are telling their staff they do have to raise it as an option, but it's not in the legislation. The guidelines and the legislation describe what you can do if you want to initiate such a discussion. And if so, they must provide certain information that's outlined. I raised this with Kerry Chant, the Chief Medical Officer of New South Wales, because I knew some local health districts were saying you have to talk about it. And she said, no, it's not a requirement in this state. But what does it mean to raise the topic? Now, this is in the guidelines for the, I don't know if I've, for New South Wales guidelines for practitioners. I actually really disagree with this. They say on the left, these are actually requests for VAD, and on the right, they're not. I would say that you can't really tell what the patient is intending from any of these, but these have actually been very dangerous because a lot of junior doctors who don't have much clinical experience have followed this advice, and a lot of them are referring patients to the VAD pathway through this vague desire for hastened death statement. In fact, and that's partly, not a lot of evidence was used to develop these guidelines. But in fact, desire for hastened death is common at the end of life. This was a study done in Melbourne after the legalisation of VAD. And they included 41 patients in a consultative service who expressed a desire to die, which was 4% of the population at the time. In this study, a desire to die statement was defined as a request made for their death to be hastened, a formal VAD request, can you tell me about VAD, a verbalised wish for their life to be over, or an expression that it would be preferable to be dead than alive. They found that psychological and existential problems were more common than physical problems, but the treating doctors tended to focus on the physical problems, not the psychological problems. Now, you see, of the 41 patients who made desire to die statements, only 7 actually went ahead to access VAD pathway to start going through the approvals, and in the end, only 2 died through the VAD process. So this is very clear, and there's been another study since that's quite similar that shows that a desire to die statement is not an equivalent of a desire to access VAD. I think New South Wales Health got it wrong on that one. Harvey Chochinov, who's a psychiatrist in the States, his research found that a desire to die statement was frequently interpreted by healthcare practitioners as a desire for euthanasia, when in fact it was a cry for help. The first challenge when someone raises the issue of assisted dying is to try to understand what the patient is trying to communicate, to explore the triggers for this statement and the meaning of the statement, to find out whether it's a true wish to hasten death or just an expression of suffering. Sometimes it can just be an acceptance of impending death or a combination of these. Existential distress and spiritual suffering in particular are very common in this setting, but often neglected. This is a systematic review examining a total of 255 patients with a desire for hastened death. The reasons given by the patients were physical factors, psychological and emotional factors, social factors, and a loss of the sense of self. But on further examination of these requests, the underlying meaning of the requests was more nuanced. A cry for help, I'm not coping. A desire to end suffering, not necessarily a desire to die. A desire to avoid being a burden on others. Often this is assumed without any overt discussion with the others involved. A desire to preserve self-determination until the end, big one in Australia, and a will to live, but not like this. So importantly, The expression may be a means to communicate needs, feelings, and wishing, or a form of control and preservation of personal agency. Next, studies across cultures have shown that these desires for hastened death tend to be consistent across cultures. And once again, in this study, there was no correlation between the number of patients making a desire to die statement and the number actually accessing the equivalent of VAD. In Australia, we're finding that a lot of people who make a desire for hastened death statement, particularly with inexperienced doctors, it's being taken as being a request for VAD. And that's a missed opportunity to understand the concerns of patients and help to relieve their suffering. What we're seeing here is the importance of spiritual suffering. In my review of over 6,000 papers in the medical literature, I looked for synonyms of spiritual suffering, and this is a sample of the terms I found. Probably the most commonly used are existential distress or demoralization. It's a huge topic, it's a huge literature, and I'll only touch on it now. But diagnosis of a life-limiting illness is known to trigger existential questions like these, which require the person to seek meaning in their experiences, to try to incorporate their imminent death into their life story. And if the individual doesn't have spiritual resources to answer these questions, spiritual suffering may result. Any threat or perceived threat to the self may result in spiritual suffering. Some people describe it as a disconnection with the person you once were. Spiritual suffering has been defined as an all-encompassing, dynamic, individual phenomenon characterized by the experience of alienation, I'm not like other people, helplessness, hopelessness, and meaninglessness in the sufferer, which is difficult for them to articulate. A lot of these people don't have the vocabulary to even tell you what's going on. It's multidimensional and usually incorporates an undesirable negative quality. I provided a link to this paper in the handout. Terminally ill patients themselves identify needs related to meaning and spirituality and hope as amongst the most important aspects of end-of-life care. This is an old paper, but it's a classic where you can see meaning in life, peace of mind, spiritual resources, all very important. This is another study of seriously ill patients where patients reported that being at peace with God was as important as freedom from pain to maintain quality of life at the end of life. So studies measuring spiritual well-being in cancer patients have found that spiritual well-being is as important as physical well-being when it comes to quality of life. So that means patients can maintain a good quality of life even as they physically deteriorate if their spiritual well-being is high. So that's enormously important to know if you care for people at the end of life. However, we have plenty of evidence that that type of care, spiritual care, is lacking. Spiritual distress develops from an experience of real, perceived, or impending loss. I can provide the slides if you like, Catherine. With terminal illness, the losses can be multiple, and it can be experienced in every human dimension. So you see a sample here. I'm sure you can think of more. But the trajectory of any terminal illness is marked by one loss after another. You might be familiar with Maslow's hierarchy of human needs, and according to Maslow, humans always focus on fulfilling their needs, the basic needs at the bottom of the pyramid before the ones towards the top. And I use this to reinforce the idea that if someone has significant physical problems, it may be difficult for them to focus on spiritual issues if you haven't addressed those physical problems. This needs to be done as a priority, and it might require a referral to palliative care. But I think there are limitations to Maslow's depiction of human experience, as we all know that all dimensions of the human interact with each other. And it may be impossible to control some of the lower factors without addressing the higher ones as well. And this is because all dimensions of the human influence each other. And those of you who are in palliative care will recognise that this is the way that Cicely Saunders, the founder of modern palliative care, described her concept of total pain in patients at the end of life. I can remember a patient I had with pancreatic cancer who developed abdominal pain, which we weren't able to control until we discovered that he had 2 sons he'd lost touch with. He hadn't spoken to them for years. We were able to get in touch, brought them in. He told them he loved them, regretted, the breakdown in their relationship. After that, we were able to control his pain. And in my research with palliative care doctors, this is a common experience, that you need to address spiritual issues as well as physical to help the whole person. I've put a link to an article on spiritual care in the handout because it's we don't have time to talk about it now. But it's not only patient factors that are significant in this situation. The importance of the therapeutic relationship cannot be underestimated with regards to how it influences a patient's fear of death and sense of suffering. Now, some of you might know Brian Kelly, a psychiatrist who's been at Newcastle University. He conducted a study of 256 terminally ill patients and their doctors in regards to how a clinician factor influences a person's desire to die. He found that not only patient factors, but also the patient's perception of how the doctor felt about their situation influenced desire to die. So doctors who had a low level of optimism about the prospects for the patient or had less training in psychosocial or palliative care were likely to increase a patient's desire to die, where conversely, desire to die diminished in the care of clinicians with psychological and palliative care training. So in other words, the therapeutic relationship has the power to infer values. Our expertise makes a difference, and this is consistent with data that shows that high-quality palliative care reduces the desire for hastened death. And it's also a reminder that some of us need to make sure we know the paths of referral for our patient and take steps to upskill ourselves. It's obvious that the first step in dealing with the desire to die statement is to equip yourself. My own response to someone who makes a euthanasia request is, what's wrong? So one way to increase your skills is to look at some of the guidelines on how to respond to these requests. I've put information in the handout. This is an evidence-based paper on how to respond to desire to die statements. There is also some information in the handbook provided by New South Wales Health on how you should respond to desire to die statements. We don't have time to go through them in detail, but you'll find the information there. So let's go back to the legislation. What do you do if a patient makes a specific request for information about VAD? This is an outline of the voluntary assisted dying process in New South Wales. There are lots of steps, but we're just going to focus on the first step right now. At the time the bill was debated, the government made a big point that they've protected individual doctors so they're not required to participate in the VAD process if they have a conscientious objection. But according to the legislation, strictly speaking, if you refuse to be involved, whether you think it's just bad medicine or have a conscientious objection, and that doesn't work on the slide either, you have a duty to inform the patient immediately that you have a conscientious objection. However, there's no prohibition in the Act to prevent you from continuing a conversation on the topic. Disclosing your objection is, however, required before you start that conversation. Now, I spoke to Kerry Chan about this as well, and I said, well, you could get the impression reading the legislation that if I have a conscientious objection, I just say, no, I'm sorry, I can't be involved, and that's it. But she said it doesn't remove the responsibility to respond appropriately to a clinical scenario. So you can still engage with the patient to go through the steps we've already outlined. Now, you don't have to say, I have a conscientious objection, I'm not going to be able to be the doctor taking you through the VAD process if it's not a real first request. So in order for it to be a real first request, it has to be made, the request has to be made in a medical consultation face-to-face between a doctor and a patient. The guidelines distinguish between someone making a request for access and someone who's simply seeking further information about voluntary assisted dying, which I think is sufficiently grey that you can still say what's wrong. A first request can't be made by a relative, though in fact they often are. So if the child of the parent who's due to go to the nursing home asks you, wouldn't it be better if they had VAD than go to a nursing home? That is not a first request. You don't have to go through these steps. It's also not a first request if the patient is obviously not eligible. You don't need to go through the steps if it's very clear they're not going to be eligible. And the guidelines suggest that you're much better off letting people know earlier rather than later that it's not an option for them. But if you determine the patient is making a very explicit first request for access to the VAD pathway, the Act requires that you document the request and the reason for your refusal of the request. I'm not going to go through the steps of if you want to be involved in the VAD pathway. I won't be going through that process today. Accepting the request makes you the coordinating doctor, which requires the VAD training provided by the State Health Department and involves eligibility assessments. If you refuse the request for reasons other than conscientious objection, you also have to give the patient information about how to access VAD. If the reason for your refusal to accept the request to help the patient is conscientious objection, you don't have to give that information. The information is available on the New South Wales Health Portal. But the law also requires you to notify the VAD board through the New South Wales Health Portal. And you can see there, within 5 business days after deciding to accept or refuse the first request, the medical practitioner must complete the approved form and give a copy of the first request form to the board. If your reason for refusal is conscientious objection, the law requires that you notify the State Health Department that you are refusing on grounds of conscientious objection. If you don't go through these steps, you could be charged with professional misconduct and you could potentially be struck from the register on grounds of not complying with this legislation. So these requirements raise the issue of complicity. Would it somehow be compromising or improper for a Christian doctor to engage in this process? Does it represent a kind of endorsement or at least insufficient clarity about the wrongness of VAD? We can imagine Christians disagreeing on this matter, and each of us needs to decide for themselves what their conscience allows them to do. We need to think carefully about how and why Someone might be implicated in the immoral action of another person. So at this point, it's important to distinguish real responsibility and meaningful participation from mere proximity and distaste. The mere fact that a person is near to or in some way involved in an action they disagree with or find objectionable doesn't necessarily mean they are ethically implicated in that action. In ethical terms, whether a doctor is morally complicit in an action will depend on several factors. Have you any role in the causation of the act? Is the patient's desire for VAD influenced by you? If you've gently counselled the patient regarding alternative paths of action, as we've already discussed, this may not be the case. Secondly, are you facilitating the morally wrong act directly? Are you making the VAD happen? Now, this is an interesting question. By documenting the request and providing information, are you helping the patient achieve their morally wrong aim? By agreeing immediately to the patient's request, you may appear to be giving the choice some kind of legitimacy that might reinforce their decision. Hence the benefit of expressing conscientious objection prior to counselling the patient. You may be the only person who ever expresses concerns about VAD to the patient, and in some ways it would be a shame to miss that opportunity. However, some people think that referral does constitute complicity and merely distances you from the morally wrong act rather than making you a value-neutral service provider. If you are convinced that referral does constitute complicity at this point, you should not go against your conscience. However, because it's the law, you may need to consider working in a different area of healthcare. Does your action perpetuate the moral wrong? Does your referral increase the likelihood of it happening again? Well, obviously, if the patient proceeds with VAD, that won't be an issue. But it's possible that by expressing your objection to VAD, you may persuade the patient to think differently about it, and this may alter their behaviour. Therefore, staying in the system and engaging with patients requesting VAD may seem to you to be the morally preferable route. But it would mean continuing to express conscientious objection. By not expressing any objection, you infer that this is a legitimate therapeutic pathway to take. A doctor who is legally obligated to enter patient details in the New South Wales Health Information Portal might find this deeply unpleasant and upsetting, but they are not necessarily complicit in the patient's death through VAD in any meaningful sense. The responsibility for this clearly falls upon the law, the third party involved, and the patient. However, it may cause moral distress, which we'll consider in a moment. Another issue on which Christians disagree is whether it makes one complicit to continue to care for the patient who has decided to die through VAD, and whether they should agree to be present in their end-of-life care and at the death. One might feel it critical to remain with the patient. You may have an opportunity to speak the gospel before the end. Another might feel that such an act would inevitably only serve to ease the patient's conscience when it ought not to be eased. You could argue that a doctor has a duty of care to continue to care for a patient who goes down the VAD pathway, and there are other examples which are less contentious, whereas doctors, we have patients who make decisions with which we don't agree. Many Christians will find this situation confronting and troubling, But we need to distinguish mere proximity to evil from responsibility for evil. When Scripture calls us to flee evil in 1 Corinthians, it's calling us, I'm sorry about my voice, it's calling us to flee evil that we might do, that we might be responsible for. It shouldn't be understood as calling us to distance ourselves from evils that we find repellent, as if we might be made unclean by mere proximity to evil. The Christian life is not lived simply according to the logic of clean and unclean, because it's not from outside, but from within that one is defiled. We know that Christ didn't ask the Father to take his disciples out of the world, but to protect them from the evil one and to sanctify them while they journey within it. No church, community, hospital is free from evil, and we should be aware of assuming that the presence of some particular evil, which has special public prominence, is uniquely corrupting. But that said, we also shouldn't be overconfident about the distinction or our capacity to make it. It's wise to be cautious and circumspect about such proximity and to be clear in our determination to touch no unclean thing. So, given the complexity of navigating situations and circumstances like these, it's inevitable that different Christians will come to different judgments about what is the right thing to do in each situation. And in this situation, it's good to think about how the Apostle Paul navigated the complexity of disagreements over different aspects of obedience in terms of realizing that each person will make their own decision according to the Lord, fully convinced in their own mind that they're acting from faith. So in a way, this is describing the idea of conscience. It's about one's felt and experienced moral convictions about one's actions after one gets educated. We need educated consciences. In such situation, Paul's argued that patience and restraint is called for between one another in order to protect the brother or sister with whom one disagrees. However, such disagreements obviously will have limits. A church trying to care for people and families wrestling with VAD couldn't possibly both endorse the view that euthanasia is an acceptable course of action and that it's not, because an attempt to tolerate both positions will be corrupting to the community and its witness. In the case of these differences, the effort to understand the opposed position may enable us to care for one another better, rather than corrupting our ability to do so. And I think also when we're trying to maintain relationships with our colleagues who make a different choice about VAD, that it calls on us to try and understand their perspective. I have had conversations with some of the strongest proponents for VAD, and they are motivated by compassion, just as I'm motivated by compassion. It's just we have different ethical opinions of what is acceptable to do to relieve the suffering that we see. So there's one thing that I find very worrying at the moment is the discussion in some local health districts about conscientious objection, claiming that conscientious objection has limits, and that measures need to be put in place to minimise the harm to patients. This is from South East Sydney Local Health District, saying that the mere assertion of a conscientious objection by a healthcare practitioner does not necessarily mean that the ethical threshold for conscientious objection has been reached, which is a nasty, ambiguous sort of a statement. It's interesting that the Australian Research Council has given a research grant to investigate conscientious objection in the context of VAD, and the lead researcher is Julian Savulescu, who is known for publishing articles that anyone who conscientiously objects to legal procedures such as euthanasia and abortion should be deregistered. So this is a serious topic.
Yes.
You could argue the state should protect conscience as a human right, but many people in Australia are arguing against this.
Yeah.
I would suggest that you need to be able to articulate your reasons for your conscientious objection, so it isn't assumed to be a thoughtless, emotional response. If you want to think more about conscientious objection for Christians in healthcare, we did write a document for CMDFA. I saw some copies on the table outside, but it's also on the website. But one thing is clear. VAD is now legal in all Australian states, and if a patient decides to take that route after you've offered all alternatives, you'll have to accept it. In our health system, elevation of patient autonomy is the highest ethical value. So this means we'll need to accept patient decisions with which we don't agree. And as I've already discussed, the individual healthcare practitioner will need to decide whether they can work in an area where patients are likely to request VAD. I know some doctors who've already made the decision to walk away. In the Canadian, I'm not sure it's the government, I think it's the government, but if it's not, it's the Medical Association, has offered a list of alternatives of areas to work in healthcare if you didn't want to engage with VAD. I remember one of them was hair transplant.
Yeah.
But they acknowledge that their new laws mean that some people won't be able to work as they have previously. But there's a lot of moral distress around now because of these laws. Moral distress arises when you know the right thing to do, but institutional constraints, the hospital, the government, make it nearly impossible to pursue the right course of action. Moral distress is what results from repeatedly not having our own values respected. When we are morally distressed, we often feel muzzled, restricted, devalued, unheard, or dismissed. We easily become fueled by anger, disgust, fear, and frustration. Over time, with repeated moral affronts, these emotions can fill us with anxiety, depletion, or depression. A sense of being fragmented can set in, leaving us to question who we are at our core. So research shows that moral distress has long-term consequences if it's not addressed as soon as it arises. If you can develop what's known as moral residue if you have repeated attacks of moral distress which aren't addressed, and this can lead to burnout. There are many reasons why this VAD law may cause moral distress. It could be that just the requirement to have to report to the health department that you have a conscientious objection you might find distressing. If your patients request VAD, you might have a sense of failure as a clinician. You might disagree with the VAD navigator's decision as to whether your patient is eligible, particularly in the area of prognosis. You might feel complicit in VAD by entering information. All these things can contribute. These are the three classic symptoms of burnout, which are common to healthcare workers compared to the general population. And these things are serious. They lead to reduced work performance and increased risk to patients. One way to combat moral distress is to cultivate moral resilience. There's been a lot of research done on moral distress in nurses, particularly. The original definition came from a nursing study. And resilience is generally considered to be the ability to recover and adapt well to stress or trauma. It ensures that the moral challenges improve rather than hurt our lives and fortifies rather than weakens the spirit. Resilience helps us to see that difficulties need not leave us permanently damaged, only temporarily challenged. another huge topic we can only touch on today. These are simple steps for building moral resilience that have been developed for nurses in the secular literature. 3 separate steps: practice self-awareness, that is, focus your attention on yourself in situations that are causing moral distress. In that situation, being self-aware means exploring your feelings. There was a wonderful paper put out when we were talking about stem cell research. It said the wisdom of repugnance. When you feel that repugnance, examine it. Why do I feel that way? What is making me feel distressed? Don't try to quash the unpleasant emotions, but explore them. Give them room to tell us something new about what's going on. Doing so helps us regain a sense of perspective, which is needed to remain calm and in control, even in situations where we're not in control. And it's been shown that in some situations, just recognising the distress I feel is moral distress can be enough to help you to recover and make it bearable. The second recommendation is to create a safe space at work to discuss ethical and moral problems before they cause moral distress. And managers have an important role in this. But in Australia now, there are Schwartz rounds are being introduced to some hospitals. I don't know if you're familiar with that, where healthcare staff get a chance to talk case histories and talk about moral dilemmas. Spiritual care providers are usually invited as well. Balance groups, which are groups of doctors where you have an opportunity to talk about challenging cases, but basically a group of peers with whom you can unload some of the things that are causing distress and have a chance to talk it through. And thirdly, increase self-care. Coping with stress and building resilience improve with good self-care. Take an inventory of your nutrition, sleep, activity, and relaxation methods. Everything is easier to cope with when you're healthy. And it's recommended that you build a moral community to make you accountable for self-care. I think for Christians, you also need to think about having a Christian support group. Now, I raised the issue of moral distress with my friends at New South Wales Health. We know from research in Victoria there's a lot of moral distress in healthcare workers, even if they're not involved in the VAD pathway, because of the radical change to the delivery of healthcare. And when I said that, asked New South Wales Health, well, are you going to provide some support for the moral distress of healthcare workers? And they said, yes, we've got this wonderful thing called community of practice for everybody who's practicing VAD. And we know from other states that it's a really enjoyable experience to get together with other VAD providers. And when I suggested that that might not be the ideal safe space for people feeling moral distress about VAD, they said, well, I'm sorry, that's all we're providing. So there's nothing in the system. We have to find our own supports. In addition, for Christians, a safe space might be a meeting with others who share your views so you can debrief about your concerns and receive moral support. We also need to protect our spiritual well-being. High spiritual well-being is associated with reduced burnout and compassion fatigue in healthcare workers. So make time for God, particularly in the early years of training. That can be really hard. But in this context, it's really important. Particularly if you care for people who are suffering, it's very taxing work. You need to take care of yourself going forward. What do I think will happen in the future? Well, I think it's going to get worse. All jurisdictions that have legalised and enacted euthanasia legislation see an increase in the number of deaths due to euthanasia over time. Canada has seen a tenfold increase in MAID deaths since its legalisation in 2016. At the moment, there's an increase of about 33% of deaths every year. These are government figures from a range of jurisdictions showing increased number of deaths over time. But it's not just an expansion of numbers, it's also an expansion of the criteria for which euthanasia is allowed. In the Netherlands, euthanasia was legalised in 2002 for terminally ill patients, but since then, so originally it was terminally ill patients who were mentally competent and experiencing intolerable suffering. But from there it's expanded to include patients who aren't terminally ill, who aren't mentally competent, who aren't adults, including disabled newborns. This year they legalised it for children. And a recent journal article described the established practice of euthanasia for multiple geriatric syndrome, also known as old age, where over a third of the deaths were primarily motivated by loneliness. How is this justified? A similar expansion of laws in Canada recently was hailed as a milestone to end discrimination against those who are not terminally ill. Once the principle of state-sanctioned killing is approved, how can it be limited to the suffering of the terminally ill? If, as in New South Wales, euthanasia is promoted as a way for citizens to exercise autonomy, artificial limitations such as short prognosis cannot stand. State-sanctioned killing becomes a liberty issue. If I decide to end my own life based on how I personally define quality of life and a meaningful existence, how can the state judge that decision on the basis of general values, societal norms, or objective rationality? I shouldn't have to justify my decision. Rather, my decision must, in principle, be respected by the state and society as an act of self-determination. In other words, once state-sanctioned killing is permitted, death on demand will eventually follow. Experience in the Netherlands suggests that another development that occurs with legalisation of euthanasia is that orchestrated death becomes normalised, and many of the patients in the Netherlands who aren't eligible for euthanasia now die through sedation. A story for another day. Finally, there is evidence overseas that over time there's increasing pressure on doctors to provide assisted dying. VAD in Australia is very popular. Patients love it. Families love it. None of that, death by appointment, none of that waiting around in the hospital room for somebody to die. What can you do? I think there's a role for the church. Churches were the first to build hospices for the dying. There's a role to support those who feel abandoned and spiritually lost at the end of life. This is another talk I give about the possibilities for the church moving into this space. There's also opportunities to empower the individual to think through how they want to approach end of life, and I'm writing a book on this topic. Personally, I think it's important we understand the laws because some health districts are telling doctors they have to do things that aren't actually in the law itself. Decide how you want to respond. Upskill so you know how to respond to a request when your patients are in distress. Share with your colleagues some of the things you find. And although I'm not here to promote political action, conscientious objection of doctors in Australia is under threat. We do need a level of political awareness. I think if more doctors had been politically aware, it's possible the laws would, maybe they hadn't gotten through, or maybe they would be better than they are. But a lot of doctors had their head in the sand and said it's never going to happen, and look where we are. There are groups trying to improve the legislation. There are some petitions going around to try and change the requirements to report conscientious objection. Pay attention to your professional group's ethical guidelines because there are some subtle changes being made that will reduce our rights for conscientious objection. And finally, we need wisdom and prayer in this difficult situation. So thank you for your attention, and I hope to take questions. Thank you.
So there's a few questions that have come through. One I think you've addressed in some sense. Somebody has said, I want nothing to do with conducting or recommending voluntary assisted dying, and knowing that I will refuse, what are the best ways to resist the legal pressure to make an effective referral? I think you answered that quite well.
Effective referrals, not is a Canadian thing we have.
Okay. Yep. Yes, so there are some things that we are required to do, and there are some things that we might choose not to do, but then we will need to have consequences about that, and that may decide where we work as well as how we work. You mentioned abuses of euthanasia overseas. Can you summarise what some of these abuses have been and what trends have become evident? Is there a clear slippery slope that's led to physician-assisted suicide being offered to groups it wasn't initially intended for? And where could we be heading if eligibility is progressively broadened with time? Can we still advocate for limitations now that the door has been opened? And I'm going to limit you to 2 minutes because I do know that there are lots of examples.
There are lots of examples. So the slippery slope, the easiest way to understand it is once the laws are passed, the eligibility criteria increase, as I've already mentioned. A lot of the problems with euthanasia is not in the original law, but in how it's implemented. And the understanding at the time these laws are passed, generally it's just for people suffering terribly at the very end of life when the death is expected within hours to days, at the most weeks. But what we're seeing is these longer timelines. ACT, no prognosis required at all. We're already on the slippery slope in Australia. There's been a lot of discussion about the need to ensure that VAD is acceptable to people with dementia. And if we are going to insist on mentally competent patients, that means we need them to be put into advanced care directives. So that's the direction. The one halt I've seen in expansion anywhere in the world is in Canada, where a couple of years ago they changed the law saying that people with a psychiatric illness only, as opposed to a physical illness, were eligible. And they've realised that they can't distinguish between suicidal ideation in someone who is psychiatrically ill and a physician-assisted suicide request in someone who may not be psychiatrically ill. So I think they're starting to realise that maybe it is the same thing, and they haven't implemented that yet. So there's definitely space when these suggestions come up to bring our medical wisdom to the discussions, to say that we're moving into very dangerous territory when we say somebody with a psychiatric illness can decide they want a doctor to kill them. And that's why we need to, rather than delete that email from the AMA saying they're reviewing their ethics code, you need to actually read it and just see what's being suggested.
Thank you. I think you also answered this, and I remember when I first listened to a information session about voluntary assisted dying, and I was told if anybody asks about voluntary assisted dying, then that is a first request, even if that person is not eligible. And I was very glad to hear later on that that does not mean a person is if a person is clearly not eligible, you do not need to submit a first request. And particularly if they're just asking questions about in the future. So how would it be now that I've just got my diagnosis of cancer? What are my options? That is not a first request when people are first looking at that question of oh, I've got cancer, what do I do with that? So, yes, that I was very relieved about that. What are the repercussions for the patient if I, as a clinician in a GP role, were to complete and submit a consultation referral form as per the legislation, citing refusal as a conscientious objector? What do I do then? And then what happens with that referral and the information that I provided to the board? Will that patient then be contacted by a voluntary assisted dying medical professional and I've therefore facilitated that process? Or will it be up to the patient to go and find another clinician who will facilitate their request?
My understanding is that the navigator system are the people who will give the patient the information they need to proceed and connect them with a coordinating doctor.
But also we have a relationship with our patients and we can continue to talk with them. And I think particularly in general practice over time, we often have much more connection and credibility to be able to ask questions about why are you asking this? What are you thinking? What are you feeling? How can I assist you here and now, and not somebody is separate from that? One of the people who has put in a text is a professional supervisor, and she said that professional supervision and reflective practice is also a great way to find support for yourself. I'm going to say Christian Medical and Dental Fellowship, just meeting with us, knowing who the Christians in the local area are, knowing who you can ask for help. There are mentorship programs here in Newcastle and around Australia. There are hospital fellowships where you can meet and pray. There are people that you can find locally to sit, discuss, talk, and get support from, so that particularly in that area of moral distress, that we don't end up with burnout and depersonalisation and walking away, throwing up our hands with it, but that we can walk alongside of our patients in that space. Another question from junior doctors. What might it look like for a junior doctor who conscientiously objects to voluntary assisted dying to work with integrity and minimal moral distress under the supervision of a consultant who's practising VAD?
The case of junior doctors is interesting. You're not actually eligible to be a coordinating practitioner until you've been working for 10 years. So they're obviously not going to be able to participate in the pathway. And so they can't accept a first request. So I think there are two issues. Is the two things that I'm aware of that are happening for junior doctors is patients making what might appear to be a first request, but also the VAD navigators are contacting junior doctors to get a prognosis to help them with eligibility criteria. I think it's quite clear that a junior doctor doesn't have the expertise to give prognosis and should say so. In terms of a first request, I think it would be reasonable, and different organisations have different structures. There are some places where you wouldn't be allowed to accept a first request. You'd need to refer it on to your senior doctor. But I think it is very hard if you work for a senior clinician who's very supportive of VAD, and some of them are very enthusiastic. It is an issue of moral distress, and it's not a new thing. You know, I once had to resign from a job because my boss wanted me to assist in abortions. I mean, it's hard, and whether you just say, I'm going to tolerate this to get through my training so that I can practice differently in the future. But you would have to put in place all those things to deal with the moral distress, or whether you think, I don't like the way this is going and I just can't work here anymore. But yes, there has been a statement to Parliament saying that doctors with conscientious objection were a barrier to junior doctors. So it's actually going the other way at parliamentary level, that doctors with conscientious objection are the ones causing the problem. So I don't think there's going to be any sympathy from an administration.
Thinking about existential distress, one of the problems that we have is because people don't have the vocabulary to express what they're feeling. So they may say, I don't want to be here anymore, I just want to die. The question is, how can we help people gain that vocabulary when time is often limited or we don't have an established rapport with the person?
It's a huge topic, existential distress. And one of the symptoms of existential distress is an inability to articulate your problems. So it's definitely an area that's a widespread problem. There are some validated sort of questionnaires you can use to try and discover elements of existential distress. One simple one for patients at the end of life is just to say, are you at peace? Which has been validated as a measure of spiritual distress. And that, in fact, is a very easy way to start to get into, but you need to learn to take a spiritual history, which is mentioned. Some guidelines are in the article I put in the handout.
Thank you. Yes, taking a spiritual history is a really helpful thing to be able to do, and part of the saline process that we run regularly with the Christian Medical Fellowship will help you with getting the words around those things and getting some practice with using those words. So doing some role plays with people who are your friends and colleagues will help you to be able to work out what the words that work for you best in those spaces are, so that you're comfortable with talking with people about things. And I think, as we all know, through working through medicine and as students, doing that practice makes a huge difference to how we come across in the long run. And it's certainly worthwhile practicing that in safe spaces. What resources can I access to better engage my colleagues in this discussion around euthanasia?
The ones in the handout.
Easy. I think I might leave it there. There are a couple more questions, but I'm going to leave it there today. Thank you very much, Megan. Could we please put our hands together for Megan? And we'd have something scared for all of us. To have somebody who has 20, 30, 40 years of thinking and expressing things in the public sphere about this issue is amazing. So thank you very much for making it up here. As we've said before...
Thank you to my husband for driving me.
Thanks, John. This talk will go onto the cmdfa.org.au website. If you've never been there before, there's a resources section, and in that resources section is a download of the CMDFA position paper for it.
There are 2 videos that I've made on the arguments for and against euthanasia, and some of you might find that helpful in talking to your colleagues on the CMDFA website.
Yes, so please do use those resources. And if you'd like paper and you prefer paper, there's some resources out there on the table outside. So please feel free to take those, read them, use them. Talk to people. If you don't talk to people, then people, especially because social media is so anti all of this, it's very easy to just be quiet and say nothing. So please talk amongst ourselves so that we get a chance to think about what matters and how it might affect each of us. If you did appreciate this event, it takes a lot of organisation to get this sort of stuff off the ground. So I particularly want to thank Koshi and Mika and Alicia and Tim who've been here, and also all of the HBC people who've helped with the coffee and more afternoon tea. We really appreciated that. And it would be great if you could support CMDFA as a member. So your membership basically helps to organise things like this so that we can pay staff to get the organisation so that Eventbrite works and advertising works and people can get together and we can have a coordinated and supported a supportive community where we can live out our Christian faith with integrity in our medical practice. You might also join the Christian Health Professionals Network. That's chpn.com.au. So that's Christian Health Professionals Network. And that's a way where you can say, hey, yes, I in a secular environment am a Christian. This is how I integrate my faith with practice. And that might be helpful in hospitals as hospital fellowships or secular organisations or in general practice, or if you're going to a different place and looking for work, or if you're wanting to refer to Christian healthcare providers. We would really encourage your support for that. A directory is really only very useful if there are people on it, so we'd really like to invite you to be on it. I'm going to pray, and then after that we have the opportunity for the next half hour or so to gather and chat over afternoon tea. Pray with me, please. Heavenly Father, maker of heaven and earth, who have created human beings in your image and loved us so much to send down your Son, Jesus Christ, incarnate in the flesh as a man, to live as you have designed us to live. Help us as we, in whatever fields we work in, see the image of you in each of our patients, in each of our colleagues, and that we might be able to practice our care and craft for each and every person as if we are the hands and feet of Jesus. Be with us, help us to be wise, help us to be thoughtful, and help us to be godly as we walk those steps. Thank you for Megan and the work that she's been doing in that space, and be with us wherever we are as we walk that space. In Jesus' precious name, amen.